Hi, everyone. Welcome to the Becoming Anchored podcast. My name is Laura Deneen. I'm your host for today's episode. I'm thrilled to bring the content to you all today. If you're new to this platform, welcome. We really are about a few different things here. We talk a lot about different mental health journeys, and more recently, we have niched down, so to speak, into the realm of body image. And all that entails. So we are all about helping our clients here at Anchored move towards peace and tenderness and ease and care of their bodies. And so that's really important to us on this platform. If you're seeking therapy and you're local to Tennessee, we would love to see you. Kelly, who is our lovely guest today, is actually the clinical director over at Nashville OCD and Anxiety Treatment Facility, and so she can share more about the services they offer as well. But if you are looking for a therapist and you're not in Tennessee, we encourage you to reach out to someone local to you. So without further ado, welcome, Kelly.
Thank you. So excited to be here.
Kelly is just a lovely colleague in the area and friend, and I'm just super excited to hear from her. I've actually attended a few of their trainings. So Nashville OCD does continuing education for other providers, and they excel in a couple different treatment areas that I'm sure she'll share about. For the content of today's episode, though, we really want to share with you all about the intersection of body dysmorphic disorder and body image. And Kelly is certainly an expert on this area. She trains and mentors clinicians in her practice on this topic as well. So welcome.
Thank you.
Yeah. It's an important topic.
It's a really important topic. And, I think it's an interesting thing, I think, because there's a lot of talk about body image.
Yeah.
I think just online there's a lot of talk about body image. Even just the word body dysmorphia is kind of thrown out there a lot, which obviously is, representative of how big of a deal it is for a lot of people. But there's also sort of a misunderstanding about the reality of what body dysmorphic disorder is, because we all have bad body image days. Most everybody does, right? And that doesn't necessarily have to be a clinical diagnosis or something you need to seek treatment for.
Sure.
I mean, obviously the ideal is to be able to feel comfortable in your body all the time, but, it's a little lofty of a goal.
Yeah. We talk about the body image spectrum here with clients, right? Like when clients come to us and they're like in a place of like significant distress, disgust, anger towards their bodies, and like moving kind of along the spectrum towards body acceptance, which does not equal like body love or even positivity.
No.
On most days for
just
a lot of people.
Tolerating.
Yeah. It's like, how can I care for my body today? How can I get my body's needs met? And I love that you shared this. It is just because someone has negative body image doesn't mean that they also have body dysmorphic disorder.
Yes, body dysmorphic disorder, if we really want to talk about like the DSM diagnosis definition, of course it's the DSM, so it's got very specific requirements, right? But we have a preoccupation with one or more specific body parts. And that body part, there's either like a non-existent flaw, or if there is a flaw, it's very small. And so the preoccupation is just sort of, an exaggeration of the intensity of that flaw. So maybe if someone does have some sort of a scar on their face, it's not like you would see it unless you were right up close.
Right.
But they're considering it to be, they're just like, completely disfigured. So there's that preoccupation, and then there are repetitive behaviors that go along with that in response to that preoccupation. And it causes significant clinical impairment, looking like maybe not able to go to school, really struggling at work. Sometimes there's, not leaving the home, co-occurring with other issues. And just on a baseline, at least about an hour a day of that preoccupation. Oftentimes it's more, closer to 3 to 8 hours a day, what it actually looks like. So yeah, that's like body dysmorphic disorder versus, I look at a picture of myself and I'm like, ugh, gross, moving on,
Yeah. Which we have interventions for that as well,
Absolutely.
right? Like, and we can support clients, if they do have that response when they look at a picture, like, hey, how do we want to respond differently, right? And we can work on that too. Right. Yeah. Can you give me an example of like various like repetitive behaviors?
Yeah. So let's back up a little bit. So, body image, right, is, just this entire topic. And I think a lot of times we think about in body dysmorphia, we see the primary targets of obsession or kind of preoccupation are oftentimes above the neck. So face, nose, skin, hair. Those are just the common, most common. Obviously, that is not it. Oftentimes also very concerned with other parts of the body, including stomach, anything, symmetry, all sorts of things, right? But so the repetitive behaviors would look very different just depending on what the body part might look like. But across the board, behaviorally, it's both what you see and what you don't see. So someone with body dysmorphia is likely, you might not even see them that much because they're so isolated. For kind of two reasons. One is they're just avoiding having to interact with the world and the body that they have, but also then they're using that time to do some of the repetitive behaviors like mirror checking, comparison. There's excessive selfie taking, amplifying,
like zooming in,
right? Zooming in, absolutely. Keeping counting, we can get very, very detailed, right? Counting hairs, we're measuring, we're doing all sorts of things. And it's just taking up a lot of time. There might be a lot of changing of clothing. There might be also a lot of, it sort of in relationship to other people. Behaviors might look like reassurance seeking, asking over and over, or just talking about a body part a lot. A lot of time spent in the mirror. A lot of time in the mirror, or any reflective surfaces, really. Windows, cameras, whatever it is.
Yeah, I mean, there's so much life-interfering behaviors, right? That terminology of it interferes with the quality of someone's life. Say they're coming to see you for the first time. And I think also with that is just the amount of shame that I would imagine you encounter. And I see this diagnosis too, but it's the amount of shame, even in disclosing, hey, Kelly, I'm spending 5 hours measuring this part of my face for symmetry.
Right.
The courage even for a client to name that and identify that with you is truly so brave.
It's huge. And so there's, I have a couple things to say about that. One is that, if we think about the prevalence of this disorder, we're talking anywhere between 1% and 3%, but the reality is that's very likely underreported because of that shame.
Totally.
Someone with body dysmorphic disorder doesn't typically seek treatment. It's usually something that someone else is asking them to do. And typically, the first place that they're seen is either in a dermatology office or in a cosmetic surgery. Because they truly do believe that I don't have a problem with the way I'm thinking. I have a problem with my body.
Right.
And so if I can get my body fixed, then that'd be fine. Now, of course, there are absolutely people who come to the realization, I can't do this, and,
and work, or have a family.
Right, exactly. Yeah. But a lot of times, even if they do present to therapy, they might be talking about, social anxiety, or they might be talking about, depression, or, things like that. And they're not actually talking about their body dysmorphic behaviors because there is so much shame.
Yeah. Well, and that's where, of course, we are doing our best here and at your practice to create that safety, right? That felt sense of safety for them to be able to close, and also engaging in appropriate assessment. That's what we train our team on. I know you guys do an amazing job at this, right? But hey, is this the full picture, or are there other layers underneath that we need to be addressing?
Yeah, and assessment is a big part of this. Again, you might not just come out and say hey, do you have body dysmorphic disorder?
Right.
Right. Or hey, it looks like you're really obsessed with your nose or whatever. But because they'll probably say no. Or they might say yes, rightfully so. I can't, or they might say nothing and then go home and be oh my God, she noticed it. I'm never going back to therapy again. Right? Yeah. So, assessment is a really big part of that, and that comes through a variety of, interventions. That's structured interviews, that's screeners, that's, just observation in the therapy room, noticing how they're sitting, what they're wearing, where they're looking or not looking, and just kind of noticing if, whatever problems they might be coming in with in therapy, they're kind of running them through the lens of, because my body,
Yeah.
because my body,
Right,
you know,
right,
because my
right.
hair, because my eye, because my scar, because my whatever it is.
Like that kind of comes back. It always comes back
Right.
to kind of that topic.
Mhm.
Yeah. And I heard you mention, so in the therapy space, right, if you're new to therapy, perhaps the language that we will use, like clinical jargon, right, is like comorbid diagnosis. Essentially means if someone has more than one diagnosis,
Yeah.
right? So you mentioned depression.
Depression.
You mentioned anxiety. I know we see this quite frequently with eating disorders,
Absolutely.
OCD.
Yeah, so, you know, body dysmorphia can occur sort of like alone, but, you know, someone doesn't have body dysmorphic disorder and not have some sort of other negative outcome a lot of times. So, yes, depression's really common. And again, it's sort of like what comes first, right? Is someone prone to depression, and so then that isolation and pulling away and negative thinking really creates the opportunity for body dysmorphic disorder to come in. Same thing with social anxiety, right? There's often there is a really heavy component of social anxiety, but someone can have social anxiety disorder and not specifically sort of like hone in on their body.
Right.
There is a big overlap between body dysmorphic disorder and eating disorders. And they are different.
Yeah, absolutely.
You know, again, the area of the bodies that are focused on and things like that. There's also, you know, an overlap with substance abuse. There's a significant portion of those with body dysmorphic disorder that end up using substances, usually alcohol first, primarily to cope with the distress that they feel when they have to go out or when they're, you know, thinking about their body. And then, of course, you know, depending on, because we have body dysmorphic disorder and we also have muscle dysmorphia, which is just a specifier. Muscle dysmorphia meaning a preoccupation with wanting muscles to be bigger, and in that case, oftentimes there's steroid use as well, which is a risk.
Yeah, there's a lot of layers here that we're addressing in a short amount of time, right? If someone comes to see us for a 15-minute
oh my
session,
gosh,
yeah, it's like, okay, we've got a lot to work through right now, and that's not to say that anyone is too much, right? But I think by the time, oftentimes our clients get to us, they have been suffering for years, and it's important, I think, as therapists to not only assess for it, but like just to see people in that. Like, yeah, this has caused you significant pain and suffering.
Yes, exactly.
Yeah.
This is a, you know, and like you said, the fact that you're showing up here is, you know, super brave.
Yeah.
It's really important to meet them where they're at. So, you know, you may notice that they want to wear sunglasses inside. And yes, ultimately, we're going to ask you to take your sunglasses off at some time, but
maybe not in the first session.
Maybe not the first session.
Right.
You know?
We got to get your buy-in.
Right, exactly. And especially, you know, so you kind of mentioned the OCD and other things. You know, I also treat OCD a good bit, and so in the OCD world, we talk a lot about ego dystonic, meaning I don't believe, like there's a part of me that knows that these thoughts aren't true. I don't believe them. They're not accurately reflecting who I am. Whereas with body dysmorphic disorder, there's a little bit more like, no, these are right.
Yeah.
You know, these thoughts are right. They're accurate, and I believe them. And so if someone sits down on your couch and the first thing you say is like, your eyebrows are fine, I mean, that's not going to be helpful.
Right. Like, that's not helpful therapy for them.
No.
Yeah.
No. So you really have to meet them where they're at.
Yeah, for sure. So how do you actually do that?
How do you actually do that? Well,
and that's a big
I
question.
don't know.
Where do I start?
I don't know. How do you do therapy?
Yeah.
Well, I mean, first of all, you know, you recognize that they're a human being, right? Human being coming in with whatever sort of concerns they have, and recognizing that, as always, people are doing things because it works for them in some way, and it's made sense in their life, even though there's all these negative consequences. You know, there's a reason why this has worked, and so we validate, like, yeah, you know, it makes a lot of sense. When we're working with someone with body dysmorphic disorder, one of the most important pieces is really good psychoeducation at the beginning of treatment.
Like, just like you just went through, like, hey, these are the criteria.
These are
we
the
need to do some, like,
criteria.
more thorough assessments.
Right. And not only that, but, you know, again, they're coming in with this idea of, like, all of my problems, or a significant part of my problems, are because of my body.
Right.
And so we really want to be able to sort of shift the mindset from it's my body's fault to, well, first of all, is it, number one, is it actually your body's fault?
Right.
You know, and what else might be going on? So is there another way to think about this? Is there another way to think about why you don't, you know, have as many friends as you want? Is it really your body, or is it that you have said no to every invitation.
It's like opening up possibility,
Right.
flexibility.
Right. So we really want to talk about, not only that there's probably an alternative explanation for some of the distressing things that are happening in their lives, but also in body dysmorphic disorder specifically, there are actual perceptual differences that are going on, which, the science of that, it gets tricky.
Yeah.
But there's research to show that when someone with body dysmorphic disorder is saying, "I see this thing on my face," they're actually seeing it. There's something different going on in their brain. People with this disorder generally have a harder time looking at the whole versus looking at parts, like an actual perceptual difference, not only in their own body, but also in someone else's body, and also in objects. So if you were to say, "Oh, this clock," I might see, "Oh, it's just a round clock and I can see the time." They might say, "The handle, it's not a handle, it's a..."
The ticker?
The ticker?
I don't know what's the official word.
Right,
I don't know.
whatever, but the shape is wrong.
Yeah.
So truly, really understanding that you're not bad. Also, this is not a vanity thing.
Yeah, I was gonna actually, that came up earlier for me when you were talking, just like busting some myths around it. And I wanted to make sure to address that because that's something actually that our clients too, with like, especially in the eating disorder population, come in, they're like, people tell me I'm vain all my life. And it's like, no, that's not it.
No, individuals with body dysmorphic disorder aren't necessarily trying to like be the most beautiful, whatever that even is.
Yeah.
They're really just searching for a sense of safety and a sense of belonging and a sense of, I can be in this world. And for whatever reason, their body has become the thing that they identify as, a barrier to that.
The problem.
Right. So it's not like, oh, I have to be the most beautiful so that everyone worships the ground I walk on. It's, I want to be able to walk into a room and feel like I belong here, or like it's safe for me to be here.
Yeah, and so I would imagine, I have a pretty good gist on the type of therapy you do. It's like, okay, how do we access belonging in different ways is part of the treatment and the motivational interviewing you're doing with them.
Yes, and recognizing that while that's maybe what they want, there's a huge part of them that's like, yeah, but until my body looks right, I'm not doing that. Right, I can't take that risk. Yeah. So, and that's where we might, basically call this exposure. Sort of like if you want to be able to have an experience where you're included, then you have to be out there.
Yeah. And can we work up to that point? Can we work on willingness, even if it feels really hard to get to that point? Yeah, it's a lot of layered work here.
It's a lot of layered work, and it's also a lot about doing less of something. So yes, we want to sort of increase the ways that we're showing up in the world, but that requires someone to decrease a lot of what they're already doing, those repetitive behaviors, right? So again, if they're spending 6 hours in the mirror, first things first is we got to start talking about like maybe 3 hours in the mirror.
Can we cut it down?
Right. Yeah. And it's not even just like standing in the mirror. It's someone with body dysmorphic disorder, especially around their face, is going to be 2 inches from the mirror. Which again reinforces that sort of part versus whole.
Right. Or there's a problem with this.
Right. If I'm right here in front of the mirror and I'm looking at this one spot on my nose, like that's all I'm going to see.
Yeah.
So even just the doing less would be like, let's just step arm's length out. Things like that.
Well, I think this is compassionate, right? I think this is one of the reasons that sometimes exposure therapy can get a bad reputation, right? We're not gonna. I don't know that it's super realistic to ask someone to go from like 6 hours a day to 0, right? It's like compassionate, it's collaborative. Effective therapy is collaborative, it's relational.
Yeah.
All the things that you're talking about today that are so important.
Yeah, and you're right that exposure therapy can sometimes be seen as sort of like harsh or mean or cruel, but the reality is I'm not trying, we're never trying to tell someone to like do something dangerous or
unsafe.
Unsafe or even, really flood someone. That's not the goal. The goal is to be able to, reinterpret what, how are your behaviors actually serving you? And are they helping and are they not? And are they doing what you think they're doing?
Or have you reached the perceived goal, right? It's like, because there is some magical thinking. I say this with
100%.
care and love, right? But like if I have this if I change this thing about my body, or maybe even if I engage in cosmetic surgery,
Yeah.
I think a lot of people with body dysmorphic disorder that have never had treatment would say, like, these thoughts are still there.
Right.
These repetitive behaviors
and
are
that
still
is
there.
true,
Yeah.
right? Because the reality is, studies show that when someone with body dysmorphic disorder gets cosmetic surgery, typically they have little improvement in their body image concerns. Sometimes it gets worse. Most often it goes to another part of the body. Because it's not about that.
Yeah.
It's about your ability to, again, see yourself as more than just this particular piece of your body, and to be able to tolerate just being a human in the world, which is not easy.
Yeah, and I'm sure, I would imagine, there's so much more work than just body, right? Like,
Oh my
even
gosh,
just
yeah.
like self-worth, of like, am I deserving of like showing up? You mentioned this like social experience, right? Like, there's a self-worth piece in this as well.
Yes, self-worth, self-esteem is usually pretty low for someone who's struggling with this. And again, that really crappy place where the behaviors that they're doing to try to solve the problem of my body, the sort of checking, the picking, the whatever, the pursuit of these quote unquote improvements, create more low self-worth because they're not successful usually. And then again, we're not getting the opportunity to get other input or sort of like data from other people. Like, if the only thing that you have to measure if you're good is if this part of your body's okay,
It's a slippery slope.
it's a really slippery slope
Yeah.
because, and chances are your body's going to change.
And we do a lot of work around like acceptance with that in the practice, as I'm sure you do too. It's like, hey, how do we like live our lives recognizing that our bodies will change, and my body is not the same at 35 that it was when I was 12, and that's actually really appropriate.
Right.
And so I'm sure that's a lot of work as well.
It is, and you kind of talk about self-worth and belonging as a really big piece. So we know that typical onset does happen right around puberty, which, makes a ton of sense, right? Our bodies are changing, things are happening socially, and suddenly the importance of being included shoots up. And so it's kind of easy to have a place to put that.
Yeah. And I would imagine it progresses.
Yeah, absolutely.
So what's the age that you guys typically see?
Well, again, like it depends. It just really depends. It depends on who's watching.
Like how involved are parents?
How involved are parents?
Do they know about it?
Yeah, and how obvious are the behaviors, right? So some, one kid might be spending a ton of time just ruminating and thinking about, like, my body, my body, my body, whereas another child may be using a tweezers to pick at their face.
Yeah.
So a parent's going to be like, hey, I see that, and they may, look for treatment a little bit earlier. But yeah, we see people across the span. I've seen 7-year-olds who are worried about their hair and want to wear a hat all the time, and 75-year-olds who are worried about their hair and want to wear a hat all the time.
Yeah, it's like a human condition, no matter what age.
Exactly.
Yeah. So what does progress look like when someone has BDD?
There's so many ways to measure that, right? Progress looks like, I feel like progress is the willingness to consider another explanation for, myself and the world and what it means to be valuable, sort of as a whole, right? That's a total mind shift. That's progress, right? Progress can look like I'm willing to consider that maybe, just maybe, it might not be this one part of my body that's the problem, but the way I'm interacting, or the way someone's treated me, or sort of cultural expectations. Or progress looks like I'm going to school again, or I'm answering texts from my friends, or I'm taking my kid to daycare rather than having my partner drop them off because I'm so embarrassed about leaving the house. So it's really that combination of sort of how you feel about yourself, maybe what you're doing less of, and maybe what you're doing more of.
Yeah. It's like
living your life, essentially. I mean, in a very, very basic nutshell way, right? But I think we see this in a lot of our clients. It's like the reduction of their quality of life. And so whatever the quality of life means for that person in line with their value system, I love all of the examples you gave. That makes a lot of sense. Yeah. Anything else that you might share about that kind of that full picture of body dysmorphic disorder, body image intersection?
Yeah, I mean, I think when we talk about body image, again, if we kind of go back to the idea of vanity, you know, I think that whether we're talking about just body image or body dysmorphic disorder, you know, there's a real sense of fear that, you know, there's something really wrong with me, and it's a threat to my basic social existence and to my value as a human being. And I think it's just really, you know, I work with OCD too, and while OCD has a lot of individuals with OCD also struggle with, you know, self-esteem and depression and all sorts of things. There's a particular kind of flavor of body dysmorphia that is just really, really scared.
Yeah.
You know, really scared of like who I am and what other people are going to think of me, and what if I'm a monster in some ways, you know? It's really sad.
It is. Yeah, and for those of us that, I mean, work with clients for that, I mean, it's a good reminder of like at the end of the day, oftentimes people are really afraid, and can we have tenderness, compassion for that fear?
Sure.
I mean, I've got a little almost 3-year-old at home. We were actually chatting before we started recording, and we have this little, like, I don't know if I've mentioned this on the podcast yet, but we have this little half bath, and we keep the lights off in there, but it's right by our nursery, so sometimes she likes to go and like wash her hands in there. And occasionally she'll shut the door with the light off, and it's really scary to her. And I've actually given that example to clients of like, hey, if you can't access compassion for your present day fear, can we have compassion for maybe younger you, or someone that you know that's like younger? I mean, because I would never want her to stay in that dark bathroom by herself, you know? And so I'm going to open the door, I'm going to comfort her when she's crying, but somewhere along the way, I think we lose sight of that as we are hardened or maybe go through hardships, like that we're all deserving of that comfort even through the fear.
Absolutely. And I think that, you know, whether it be parenting or as a therapist or even just like working on yourself, we're trying to find the way and that sort of balance between I'm comforting you in your fear,
right,
and I'm also not letting that be the only thing I'm doing.
Sure, like I'm not accommodating.
Right. Yeah. I'm like, you know what? It was really scary for you to be in the bathroom with the lights off. That's so true. And also, that's what happens.
Right, and mommy's right here.
Right.
Yeah.
And I'll let you know that, like, hey, this is what the light switch is. This is how you turn it on. Because I want you to be able to potentially help solve that problem. You know, and so, yeah, in a therapeutic way, we are absolutely meeting with compassion and understanding. And yes, I can see that this is terrifying for you. And I'm asking you to do something really, really scary by, like, not keeping track of this perceived flaw. And also, I'm not willing to let you continue to you know, live in a way that's hurting you.
Yeah. There's an appropriate, I think, level of, like, challenging, maybe pushing. I don't know if that's like,
yeah,
you know,
it's pushing.
But it's pushing. It's like,
it is pushing.
Because I think that sometimes if we don't get good training in this area as therapists, that's something that I think is missed oftentimes within the therapeutic space, right? Of like, yes, the fear deserves tenderness.
Yes.
And at the same time, are we making a choice from that perceived threat that you talked about, the keyword here being perceived, right?
Absolutely. Yeah, I mean, there's only so many, I mean, I could really get on a soapbox about
Do it, I love it.
I have a real hard time. I mean, obviously, you know, person-centered and supportive and validating therapy work is, like, you know, at the root of everything you do.
Right, I would hope all therapists would be person-centered, meaning that they, like, want their client to do it.
That's right, and you're able to really validate and say, yeah, that makes sense. But we also have to be able to be strong enough as therapists to say, this is why it doesn't make sense.
Yeah.
And like, you really shouldn't do that anymore.
Right, and this is clearly not helping you.
Right. I'm just like asking you to maybe consider that that's not a great idea. Mm-hmm. And if I don't have, you know, the sort of strength in my own, you know, beliefs about my ability to give bad news, then I might not do that. And I say bad news, this is just something I feel like a lot of times people come into being a therapist because I'm a really good listener and I really, you know, I help people feel better. But I truly feel like a huge part of being a therapist is you have to be able to get them to see the bad news.
And the feedback.
Yeah.
You have to. And
yeah,
I love that you're talking about this because I've recently talked to just some various different providers and colleagues about like some of the kind of missing gaps in our training, right? And I understand there's only so much they can do with the time allotted in a 60-hour clinical mental health counseling degree. And some of this is going to be learned through different jobs, lived experience, all the things. And I agree with you. It's so much more than listening and building rapport.
Yeah.
So much more. It's like the giving feedback, encouraging, equipping. Do they have the skills to be able to do what I'm asking them to do?
A big part of, I think, being a therapist is being able to ask someone to take responsibility for their own stuff.
Right. Like actions have consequences.
Right.
And there's no shame. And we're here to tell you we can equip you to engage in different actions so that we have different outcomes.
Right.
Yeah.
You know, and I want to help you understand why, of course, it makes sense that you've done all these things this way.
Yeah.
And I understand why you might want to continue to do that. And there are valid reasons why you should just do the thing you've always been doing because it's worked for you. And at the same time, you know, it's not going to work. You're not going to get what you want. And it's reinforcing ideas that aren't necessarily true about the world.
Yeah.
You know, like body dysmorphia. Yes, you're right. Like certain, you know, aesthetics have certain outcomes, right? If someone looks a certain way, they might have more access to opportunities, and that is true. You know, research shows.
Right.
That
And we can do the grief work around it.
Right.
Yeah.
Exactly. However, I'm not gonna be willing to have you continuously go back to this sort of like, yeah, but if only I looked, if this, you know, that's not going to be helpful. So we really need to start taking responsibility for outside of this one particular thing you're so focused on, what else might be helpful in being able to improve your life.
Yeah, because I think the problem with that is the helplessness there. Right, and what you're talking about is just like this agency that is available to all of us, no matter what we've been through. And I think a lot of clients need support in understanding that.
Yeah, and I think that really, you know, when you have the relationship with a client where you can both validate whatever's going on, but also point out the fact that they have agency and be the one who cheerleads them into using that agency, like that's a real therapeutic relationship.
For sure. And that's like where actual progress is made.
Right. You know, as you know, if I'm working with someone with body dysmorphia and I'm like, just take your hat off. Well, no. But like, hey, let's consider what do you think's going to happen if you take your hat off? You know, let's try it. I'll do it with you if you really want me to. Like, let's go to Target. That's cool.
Yeah,
I'm always down for that.
I love it.
And then we'll talk about it.
Yeah.
You know, what did you perceive? Because I had a different experience.
Yeah.
You know, I didn't notice that person looking at you, and quite frankly, I'm not so sure that that was true.
Yeah.
And also, if they were, how can we make sense of that and still have a life worth living?
Yeah, like another perspective is how can we place less value in other people's opinions if you did perceive this. Yeah, totally. Yeah, I love the soapbox. I'm with you. I say that frequently to my team. I'm like, okay, just this one last thing. I'm just gonna say it.
Yeah, I mean, and quite honestly, and then I'll be done. But a therapist who is really, really great at validating is really, really great at validating. But validation feels good until it's invalidating. And what I mean by that is you'll see a client who comes in and you're validating, and they keep coming in and they keep telling you, I'm not okay, I'm not okay, I'm not okay.
Right.
And you're like, you're not okay, you're not okay, you're not okay.
Yeah.
Eventually that feels like, but you don't get it. And, which is invalidating, right? So, you know, if we're only noticing what they're saying, kind of reflecting and acknowledging how hard it is, eventually that is just as dissatisfying as someone who's like, you're fine.
Yeah, totally. No, I'm with you. Yeah. Well, their symptoms probably, if they're coming in and saying, I'm not okay, nothing's getting better, it's like, what do we need to do as therapists to evaluate that? Yeah, totally. This has been a great conversation. Thank you.
Yeah.
I was so excited to have Kelly on, and she's got kids, and I know your schedule's
Yeah.
packed, and so I'm
Yeah.
just like super grateful
Yeah.
for your time.
Yeah, and I know we want to wrap up, but I want to say one more thing just about specifically like treatment for body dysmorphic disorder, and that is, so cognitive behavioral therapy is really the first line treatment, and that encompasses a lot of things, some different kinds of thought challenging, absolutely some acceptance work, some mindfulness work, but also that sort of perceptual retraining where we really are asking someone to, on purpose, like we're practicing scanning your entire face instead of usually if you're engaging in a sort of a checking ritual, it looks like I stop at that spot and I hover. Right, so we're practicing purposefully moving to the whole thing, and non-judgmentally describing, you can do that with self, others, objects, and that it's a practice, right? So if you even if you're not struggling with body dysmorphic disorder, I encourage you to just even consider like, can I? For me, it's at my house, I get real hung up on so many things, but it's the like popped drywall screws. Where like my children are running around and so my walls are gonna collapse, I guess. But I can become very fixated on those and be like, oh, that's the thing. This house is a piece of crap and we have to move. But like, we're not moving. So my challenge is to be able to look at the drywall screw that's popped out and just keep going with my eyes, even though they want to hover.
No, I appreciate your vulnerability with that. Actually, something else for my house was coming to mind. My sofa. We got we have a dog, and he's an inside dog, and just we love hosting people, and so we have a lot of people in our home frequently. And anyway, when we bought it, it said like anti-pills, and so I've done a lot of of my own therapeutic work that I won't get into today, so it's not as distressing as it used to be. However, but sometimes occasionally I'm like, why? Yes. And so today when I go home, I'm gonna actually practice this skill.
It's really important.
Yeah.
It's for me. Yeah, it's the drywall screws and then it's the pile of shoes. A lot of my clients know about my pile of shoes.
Your pile of shoes. Yeah.
I mean, we've had a pile of shoes since since I had my first child 13 years ago, and it's only gotten bigger. And I've tried a lot of different things. There's
shoe racks, all the
baskets,
things.
racks, let it be. And the reality is, I have to just recognize that like there's a pile of shoes, and some people are going to see my shoes, they might even smell them.
Yeah. It's okay if
But
my
that's
couch
okay.
has pills on it.
Right, and if I say no to like someone coming over because I'm so worried about what they're going to think about that one part of my house, well, that's a bummer.
Yeah, you're missing out on that connection.
Absolutely.
Yeah, totally. Thank you so much.
Yeah.
We'll have to have you back for sure.
Absolutely.
Do you want to close with homework or an affirmation today?
Gosh. I mean, I'm really good at giving homework.
No, I love it.
Well, that's good at affirmation, but again, I guess my homework is that, whether it be an object that maybe is kind of bothering you, whether it be a scratch in your car or, a freckle on your arm or whatever it is, maybe, and not even in yourself, but maybe someone else, just seeing if you could practice moving from that sort of like lingering and fixation and then interpretation of what all of the terrible things that particular thing means about you and your future in the world.
Yeah.
Just see if you can practice, yep, there that is. And how does that, relate to the entire object or person in a non-judgmental way?
Love it. There's like so much zooming out.
Yes,
Yeah.
absolutely.
Yeah, and I mean, one thing that's coming to mind that just really stood out that we kept coming back to in today's show is just this idea that like I deserve a meaningful and full life.
Yes, right.
And body dysmorphic disorder and body image distress at large, I think, takes away from that. And so
Yeah.
you're so deserving, if you're listening today, of a meaningful life and a full life. So thanks, Kelly, for being on.
Absolutely.
Yeah, so how can our listeners find you?
Well, our website at Nashville OCD and Anxiety Treatment Center is ocdnashville.com. There's all sorts of information on there about our providers and treatment and everything. We also have a blog that actually is really great. On Instagram, it's OCD Nashville. Our director, Amy, has been known for her comics that are really
They're awesome.
fun and, really digestible ways for some really good psychoeducation. So reach out at social media or at the website.
Yeah, I can't speak highly enough of Kelly and Amy and their practice and the work that you guys are doing over there. You all have just like a phenomenal reputation in the Nashville area, and so we're grateful. It's important work.
Yeah, it is.
Thanks for being here, you all, and we will see you next time on the Becoming Anchor podcast. Take care.